Hello, welcome to this presentation on brain injuries, mental health, and substance abuse, and how therapeutic recreation is often the antidote, may often be the antidote to all of these conditions. And my name is Dan Schiavo. I am doing this in collaboration with Randy Blywas, Executive Director at Beacon Place and Director of Harbor Crest Counseling. Thank you for joining us today. I'm going to do this with a heavy emphasis on brain injury because brain injury is the population I was working with when I saw how all of these are connected, mental health, brain injury, substance abuse, and how we play an integral role in all of these conditions. And brain injury is often misidentified as mental health and substance abuse issues, and there's an inexplicable link between the three, as we will see. Causes of brain injury, traumatic brain injury, include motor vehicle accidents, falls, gunshot wounds, sports injuries, workplace injuries, child abuse, domestic violence, military actions, and other injuries caused by trauma. Strokes, of course, is an acquired brain injury, but brain injury is brain injury. So, as we'll see, it's all relatively the same. A brain injury is a brain injury is a brain injury, and it depends on what part of the brain gets injured and how severely it's affected, and the longevity of how long symptoms last, etc., 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 will determine the treatment and etiology of the brain injury. Stats on brain injury. Every 23 seconds, one person in the U.S. Sustains a brain injury. 1.4 million traumatic brain injuries occur every year. 235,000 people are hospitalized each year with a brain injury. 80 to 90,000 Americans experience onset of long-term disability each year following a brain injury, and the actual number is higher. I can't emphasize this enough, and we'll talk more about this throughout the presentation. TBIs are often not reported, and that's part of the reason for the misdiagnosis of the condition. As a matter of fact, brain injuries have been around since the beginning of mankind, but it's only been in the last 15 or so years that we really had a lot of research with brain injuries. Number of people each year in the Hudson Valley area, which is where I was working at the time, who with brain injuries add up emergency room visits about 10,000 a year for everybody in the Hudson Valley each year. And there's probably a lot more people who ought to have gone to the emergency room. Over 2,200 people die in the state from brain injuries every year. And over 120,000 people in the whole state of New York go to the hospital. Almost 20,000 people die are hospitalized with a brain injury each year. How does a brain injury happen? It's usually after a sudden jolt of brain for traumatic brain injury. The contra coup, basically in whatever direction, front or back or side to side, the brain crashes against the skull, which have a lot of actually is a lot of how do I say it? Jagged edges. There's actually jagged ridges in the skull, which I don't know. From all the pictures of skulls I've seen, I don't think I've ever actually seen that. But apparently there is. And the brain is very fragile. It's actually somewhat easy to get injured because it really is very kind of fluid, and actually that's also the good part because brain injuries can heal. The brain is made up of many neurons, billions and billions of tiny brain cells making up the central nervous system, which shoot signals back and forth through the nervous system to and from the brain. You want to move your arm, there's signals to and from the brain going back and forth for just one motion. Made up of axons, cell body, neuron, dendrites, synapse, um, and and like lightning, it shoots across the axons, as you see in the picture, from and go from one cell to the other. The chemicals and the electrical activity. Glial is the glue, non-communicating cells supporting and nourishing the neuron. Okay, mechanisms of traumatic brain injury, diffuse axonal injuries. Delicate nerve tissues, they rip, tear, stretch, and that's kind of what creates the injury. Swelling, brain tissue swells, preventing blood and spinal fluid circulation. Sometimes when people first have a coma, first go into have a brain injury, and in our area, in the Hudson Valley area anyway, they are often flown to Westchester Medical Center and induced into a coma to prevent the swelling of the brain, because otherwise the brain will get too big for the skull, and that would kill them. Hematoma, accumulation of blood causing pressure. That is basically when the blood is flowing so much, and there's a blockage. So sometimes the hematoma and hydrocephalus go together. Blockage of cerebrospinal fluid causing pressure, and it's almost like a balloon that has a knot, and the air is still rushing through, and it just gets big because the air just can't go through. That's kind of what this is. Anoxia and hypoxia, oxygen loss, deprivation from suffocation, drowning, blood loss, cardiac failure that kills brain cells. I work on a trach unit. A lot of our folks have had that, often from a stroke, other cardiac event, cardiac arrest. And there was one person I worked with at Beacon Place, and it's a public story. It was in the paper, so I'm not violating HIPAA or anything. It is their oxygen was cut off. They were like a commercial scuba diver for a construction company, and they were 70 feet under, and their oxygen was totally cut off. And they came up, and they went right into cardiac arrest. They were clinically dead for 22 minutes. They revived him, and he was in a coma for 5 months, and in the hospital for about 18 months, I believe. And but as a result, he's got significant brain damage. Hemorrhages, that's basically bleeding of the brain, and basically this happens in a concussion as well. And of course, concussions aren't usually permanent, but there is post-concussive syndrome where the brain actually, their effects last longer than just temporary. Yeah. So that's basically what hemorrhaging is, and of course with strokes, there's what's called a hemorrhagic strokes. Most strokes are ischemic. About 80% of them are ischemic strokes, but hemorrhagic strokes, which cause the brain to bleed, basically is only about 20% of people have it, and actually survival rate is about 50-50 for it. So now we get into the brainstem. This is kind of the basics of life and death, really. This is the real parts of us that have been around since we were cave people. Bears were chasing us and all that jazz. But, we have the midbrain, which is about alertness and arousal. And some people who I work with, they have been kind of, almost everything else is gone, except for their ability to startle and get that kind of arousal. And but yeah, alertness and arousal, elementary forms of hearing and seeing is the midbrain. Pons, facial movements, uh, sensation, hearing, coordinating eye movements. And if somebody's area of the brain is injured a little bit there, they might have issues with facial movement, sensation, hearing, and that's why and that's part of the reason I'm, going through the brain, because if some of these areas are off, people will have problems with them, right. And that's basically what a brain injury is. Medulla is essential to basic living functions, vital to life and death. Breathing, heart rate, blood pressure, vomiting, sneezing, all of those senses. Right. And that's why, it's very essential that we have a medulla, because that's what keeps people alive. As a matter of fact, the brainstem and the medulla, that's the area if you really want to kill somebody, like you see in the Godfather movies and that type of a thing. They will shoot people right in the area where the brainstem is, because that for sure will kill them. Thalamus and hypothalamus. Thalamus is the major relay station for incoming and outgoing sensory information. The input for every sense except smell travels through the thalamus. So our senses go through the thalamus, and we've had those. This is still pretty much the inner part of the brain, the reptilian part. That's been around for thousands of years, basically since since we started as a species. Hypothalamus is a control center for hunger, thirst, sexual response, endocrine level, and temperature regulation. And it also controls complex emotions like for anger, fatigue, memory, and calmness. The limbic system. This has been around also since we began. It houses basic elemental drives, emotions, and survival instincts. The amygdala is basically the fight or flight response. So if when we were cave people and we were constantly chased by bears, we would either learn to fight the bear or run like hell. I personally would probably run like hell, because I don't know if I would have much of a chance against a bear.
I'd fight against the bear.
But of course, the amygdala is, sometimes nowadays gets us into trouble because it's still constantly searching for threats. So if we get angry or anxious, it's usually because of the amygdala. And my friend Gene, he said, Amy G. Dalla, the amygdala, in other words. So if anything goes wrong, if you have issues with anger and anxiety, blame Amy G. Dalla, the amygdala. Blame Amy, yeah. And that's what is, we have to kind of notice when Amy is kind of triggering us, and then we kind of have to blame Amy, and not to let it trigger us. We gotta use our hippocampus, which is the next thing I'm going to talk about, and that's big because that's where memories and stuff are stored. When we're in a traumatic situation, when we're in that fight or flight response, our sense of the world is kind of inaccurate. Anyway, so many people, for example, have a irrational fear of spiders, which often develop like when they were children, and in our minds, we make the spider look very, very big if you're scared of spiders, very big and nasty. And at the time, you were a child, so you felt small, and the spider, in your mind was probably much bigger than it actually is. So change the picture, and because the hippocampus is a very visual memories. So you're big now, and the spider is small, and that kind of puts it in perspective. And This is kind of what's used also sometimes in like hypnosis and different types of neurolinguistic types of therapies is with people who have had trauma, because and this is true for brain injury too, that even though the memory, people with brain injury, the memories are a little bit distorted or not there. Um, they remember in their minds everything about the event, who they were with, what the air smelled like, what color the sky was. Was it cloudy? Was it um, because it's just such a traumatic event to have a car accident or something like that. Yeah, you kind of remember everything that happened very vividly. So, and you're, really in fight or flight response there. So people can have a trauma. They could be scared to drive again. They could be scared to, um, kind of, they have flashbacks, nightmares. So they have to visualize a different story for themselves. Yeah. So, which is sometimes more accurate, and that's, in terms of what actually happened. And that's kind of what, sometimes neurolinguistics and other therapies all about. But yeah, if this is off, behavior and mood can be very erratic, as it says on the slide. We just went over this amygdala fight or flight structure, the front door to our emotions. When perceptions reach the cerebral cortex, it is transmitted to the amygdala to be evaluated for emotional content. Um, Hippocampus is associated with memory functions. Injury can result in problems with short-term memory and turning short-term memories into long-term memories. Um, Disrupts the encoding and retrieval of long-term memories. So, in other words, people with issues with the hippocampus, is almost like having a bad computer, where the computer has trouble encoding the information. That just like our minds in some ways is a little bit like a computer. The information goes in, it gets processed, and then goes out of us in the form of whether it's a test or something on the job. We kind of regurgitate that information, which is kind of like a computer. Information goes in, it's processed, and we can get it back. But somewhere along the lines, if there's an issue with the hippocampus, there's some kind of like a malfunction almost with the brain, just like it would be with the computer in terms of that process I just described. Taking information in, encoding it, and then retrieving it. The lobes of the brain. The frontal lobe is, basically a lot about who we are. It, controls our personality, um, perception, and attention, concentration, organization, sequencing. A lot of who we are. Back in the dark ages of mental health, they often used to have lobotomies, which is basically taking out people's frontal lobes of the brain. Bad idea, because when that happened, the people ended up like zombies primarily. So that turned out to not be a good idea. But fortunately, we're no longer in the dark ages. And of course, it's also certain conditions like, well, brain injury, but also ADHD, and it is another one. ADD, ADHD is another area that is often associated with this, the frontal lobe, because it is regards to attention, concentration, organization, and it's often understimulated. Even if somebody's hyperactive, the area is usually understimulated, and that's why people are given Ritalin and other things that are a stimulant for that area of the brain, including coffee is actually also a stimulant, and that's kind of what makes people feel more alert and awake and focused, and potentially after drinking coffee, especially in the morning. The occipital lobe is kind of equal with the eyes, and that is responsible for vision and visual perception, and it is also one of the areas where that is associated with reading, and a lot of people with a brain injury to that area actually have to learn how to read all over again. And that's a big part of brain injury is, especially when that happens. And that's a big challenge for a lot of people. And the parietal lobe is, visual perception. And, if you're backing out a car, that's what is the lobe that is going to keep you from hitting people and objects and everything else, and knowing how much room you have to back out, etc. Um, and temporal lobe, memory, hearing, expressive and receptive language, musical awareness as well. But a lot of people who have strokes have issues with expressive language, and can't speak as well. We have quite a bit of this in the nursing home where I work right now. And it's very difficult to understand what they're saying, and it's especially frustrating for them because a lot of them actually do understand everything that's being said, but they just can't communicate as well. Cerebellum is another part of the brain that is associated with balance, coordination, that type of a thing. And that's why actually it's good sometimes to let an officer know if you have a brain injury, especially to the cerebellum. Like, there's no way somebody with an issue to the cerebellum is going to be able to pass some of those field sobriety tests that officers give. Really, it's really good for officers to understand not only brain injury but mental health issues and substance abuse in terms of how to actually help people with these conditions, because a lot of them just don't know how to work with people who have these kind of issues. So and actually there was a thing online that I saw, and I actually, well, this was after I worked at the Brain Injury Center, but I sent them the information that they could get a card, describing that the people have a brain injury and a quick rundown of the symptoms, and here's what it looks like. So, but yeah, this is a basic rundown of brain and behavior relationships, basically what I pretty much described on the previous page. Common TBI symptoms. Some other common TBI symptoms: headaches, memory deficits, difficulty word finding, fatigue, changes in emotion. Sometimes people will have like flat emotion where it's almost like they are not expressive at all. They just have a very flat affect no matter what's going on around them. And so, some people have amplified emotion where they're, amplified emotion to everything. So it depends on the situation. Lack of inhibitions. Like some people are hypersexual. Some people are, will go out into the road without realizing that if you jump out in front of a car, the car might hit me, kind of a thing. So they might feel like they're invincible. Trouble analyzing social situations. And you could kind of see how some of that actually can mimic other things, like people with mania often have, bipolar disorder, mania, also have lack of inhibitions, and people with, autism and other conditions have trouble analyzing social situations. So changes in sleep. A lot of people with dementia are very nocturnal, and they are mostly awake at night. This is important to talk about how, this can sometimes be, brain injuries is often the link that's sometimes misdiagnosed as other conditions. And that's why in some ways it's important to diagnose it correctly, especially since, you can definitely possibly prescribe medicines, a little bit differently for people who have brain injuries. Prescribe medicines and other treatments, etc. Concentration, impulsiveness, I mean, people with ADD have that, and often TBIs as well. That there's another area where it could be misdiagnosed. And of course, it's also one of the things where it could be some of the reasons that people with these conditions are not can't get stable even with medication if there's an underlying brain injury. It could be the reason why people, don't get stable. Overload, sensory overload is often common with TBIs. It's brought on by large crowds. There's lots of noise or information presented too quickly, which is kind of common for people with, anxiety and autism too, is sensory overload. Inability to process external environment, fatigue, rise in emotions, some of the brain injury symptoms and other things are triggered by, large crowds, noise, all of these things. Other changes in thinking, lack of awareness of deficits. I don't even want to. Anosognosia. Yeah, anosognosia is, I guess, how do you pronounce that? But confusion, distractibility, reduced ability to pay attention, difficulty with changes in routing, calculations. Some people might have to learn how to count again, and add and subtract, and basic life skills after a brain injury. Not that much different than somebody with different types of developmental disabilities as well. So there's a great overlap of how a brain injury could be missed, or even after a brain injury, symptoms, if somebody already has a condition, symptoms could get worse because the brain injury would make it worse. Difficulty sequencing. A lot of people, when cooking or doing a complex task like that, know to maybe first, take out this ingredient and that ingredient and the cutting board and everything else that they need. Somebody with a brain injury might lose that ability to sequence what tasks to do in which order. So that's a common thing that, and with the New York State TBI waiver, as we will see, participants can learn about these areas in different settings and very hands-on. And between all of the supports available, eventually they'll get how to sequence the different tasks and break down those tasks into manageable parts. Difficulty knowing what is important, impaired abstract thinking. I could think of one person who, if you told them that what they're doing is annoying or obnoxious, they're not going to get that. You got to be very specific and say, when you talk about, I don't know, politics, that can be considered. When you keep repeating everything that Trump says, that can be considered obnoxious. I mean, really, when you think about it, that's actually good feedback for anybody who's has to give feedback, because if you call somebody annoying and obnoxious, that could just be kind of seen as name calling and not very specific to the behavior that you want to change with somebody. But perseveration, fixate on one topic. I mean, everybody, you probably all work with people who, fixate on one topic and they just don't want to switch gears. So, and that's kind of what perseveration is. Difficulty with cause and effect. Again, I use that example before, that if I walk in front of a car, I can get hit. Some people just won't get that cause and effect if they have a brain injury, and there's many other examples of that too. But that's just, you get the idea. Impaired safety awareness. As I was just kind of saying with my cause and effect example, people with brain injuries will have sometimes impaired safety awareness, poor insight, lack of empathy. And yeah, sometimes it might not always be lack of empathy. I think sometimes it's trouble identifying what other people are feeling. They might actually care about other people, but they have trouble identifying what other people are feeling and how to act in response, and all the complex kind of social dynamics that is, sometimes lost with people who have brain injury. There's, behavioral and emotional changes, ability to respond to requests. Sometimes it's just not there. You could ask somebody to do something, and they're gonna forget 2 minutes later. Aggression, property destruction, yelling at angry outbursts, which could look like somebody with autism, or self-injury, which could mimic borderline personality disorders. The disorder, decreased frustration tolerance, lability, mood, depression, and sometimes it's kind of a vicious cycle. If somebody has a brain injury and they're sent home after being in the hospital with no supports and services, they're going to get depressed, pick up substances, and that's how the chain of events kind of starts with you have a brain injury and now mental health issues and substance abuse issues. It kind of all is connected and kind of plays each other in a negative cycle. And we're uniquely qualified to, kind of make it more of a positive cycle. So impulsivity, hyperactivity, we talked a little bit about that. Inappropriate sexual behavior, immature, self-focused behavior, kind of very egocentric. I remember working with kids where we attempted to get kids to go from like parallel play to playing with another student, so kind of moving them out of their comfort zone. And that's kind of what we do as recreational therapists in many ways, is help people, gradually and comfortably expand their comfort zone. Even getting people to who don't want to sing or like are self-conscious to sing, say karaoke, or making that kind of environment warm and inviting. So, we'll talk about how we are in such a unique position to, regardless of all these laundry lists of symptoms, we are, in a unique situation where we could help, because it doesn't really matter the cause of the symptoms. Any way you think about it, we could, help these symptoms. Hoarding, decreased sensitivity to others, paranoia, and there's sometimes a reality within that paranoia. There could be a reason that people are a little bit paranoid. Anxiety, trauma, of course, just the fact that they have brain injuries is often traumatic. And the cause of the brain injury is often traumatic. Like I was saying, sometimes people remember everything about their accident, and they have nightmares and they have flashbacks, and that's a real thing to deal with, a real mental health issue to deal with. So as you can see, I put a list of overlapping diagnoses in here. Depression, PTSD, anxiety disorders, autism, dementia, borderline personality disorder, schizophrenia, substance use disorders, ADD, ADHD, dementia, and oftentimes it is often misdiagnosed as one of those conditions. So, and it's really one of those things where they play on each other. People sometimes might be more likely, if they have bipolar disorder and they're manic, they're more likely to get a brain injury, and pick up substances. So it kind of it goes hand in hand, as well as people with, say, substance use disorders. They often sometimes can hit their head when they're drunk, not report it, and they have a brain injury that is the underlying thing that keeps them from getting sober as well. So this kind of all goes hand in hand, and of course, just being home without a lot of supports can having a trauma and getting depression can make things worse, and pick up substances, and their symptoms get worse. They get a brain injury, and then they also have all the mental health issues. So, it often goes hand in hand in hand, whichever way you look at it. But either way, as you can see by the symptoms, brain injuries can be misdiagnosed as other mental health issues. That's one of the takeaways I want you to get from this presentation. But brain injuries can exacerbate already existing psychological disorders, as we just talked about. If you have anxiety or depression or whatever, and you then have a brain injury, that can make the symptoms get worse. Potential isolation and struggles after a brain injury can contribute to substance abuse issues. A lot of the people, like I said, until the past 20, 25 years, have had, there was no place for people to go during the day. When you were sent home from the hospital and or rehab, you were sitting at home. You didn't really have a day program or anything to go to. And so those people got more isolated and depressed and everything, and they picked up substances, and it was a negative spiral. But we're going to try to make it a positive spiral because we are uniquely qualified to address a lot of these issues. Substance abuse and mental health issues can contribute to brain injuries being undiagnosed. So, as we were kind of saying, because the symptoms look a lot alike, and especially since, how do I say it? People like NFL players, kind of sometimes don't even have concussions, but they have had a lot of pre-concussive blows to the brain. And, if they're hit after time after time after time, it could actually be a while after leaving football that they get these issues. And they start acting strange, and they start having, um, anxiety, memory lapses, feeling panicked for no reason. And, it's an underlying brain injury that, sometimes is therefore misdiagnosed as a mental health issue. And, then they wonder why they can't get stable and end up with substance abuse issues, and things get worse and worse. So, whatever the people's issues are, we are in a unique situation to address this dynamic. Often refreshingly, we focus on people's strengths for a population that has had plenty of struggles and been misunderstood. We enhance life quality, happiness, focus, mobility, cognition, everyday life skills. We could get people into the community again, learning how to interact with each other, socialize, um, always doing cognitive activities. We get people to have fun and meaning again. As I was saying, we take people into real life settings to practice communication, interpersonal interactions, etc. Creativity. People tell their stories through arts, music, games, crafts, writing, etc. We're much more uniquely in a fun position for people to open up to us. Whereas, a psychiatrist or psychologist, somebody the person hardly knows, will come in and ask probing questions for, 10, 15 minutes, write a script and leave. Whereas we really take our time with people and get to know people and their interests and strengths and resources. And, we use arts and music and games and crafts and things that get people to process their thoughts and feelings. And we educate people and families on how to integrate into the community and build bonds together, leisure education. And we also educate people and families how to make fun use of their leisure time. What resources are available in the community, where to go to have fun, etc. We are the fun therapists that people end up talking to and opening up to. we utilize humor to help people gain perspective on their lives. I mean, sometimes people just have to realize that, there might be other people who are much worse off than they are. We are unique in our role on debriefing and processing thoughts, feelings, and connecting stories to real life. Like, I remember when I was working with kids, you know, uh, we talked, we connected a lot of things with fun and games to real life. I mean, for example, swinging a baseball bat, there are some pitches that you just have to go for. And there are some pitches that, are not good pitches, not good to hit. You just got to lay off of it. So, which is kind of like life. There's some opportunities you just got to go for, and if it's a good enough opportunity, and there are some opportunities where, you just got to pick not to do it because it's not a good decision. So practical strategies I've learned over the years to help people with regardless of the diagnosis, but in brain injury specific, I mean, especially this first one, concrete feedback about specific behaviors. But like I said, this is really good for everybody that that those abstract concepts of saying a label for somebody, like saying that that person is obnoxious or that person is annoying, those people won't pick up necessarily what behaviors are causing that label. So you have to actually give them concrete feedback as to what behaviors are causing those issues. Repetition in multiple settings. This is the beauty of, say, the New York State brain injury, traumatic brain injury waiver program, which is for people with a brain injury age 18 to 50 to 64 who are Medicaid eligible. And if you're over 64, you could get on the nursing home transition and diversion waiver, which can also give you the same supports, basically. But, you're set up with a service coordinator who helps you with setting up appointments and money management and your basic life organizer. Your basic life organizer is basically the service coordinator, and they could set you up with a structured day program, a place to go every day, and you could use different providers for service coordination and structured day program, and then at both places you kind of learn a lot of the same skills. At the structured day program, you could even work on other basic life skills like cooking and 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 socializing in the community. So basically, and that's a very hands-on situation because obviously the more hands-on, the better. And then, of course, there's positive behavioral interventions and supports, which is basically a bachelor's level clinicians helping people work on specific behaviors. Community integration counseling, which is basically a lot of leisure education and other ways for people to integrate into the community with master's level clinicians who are helping them. And of course, independent living skills training, which is one-to-one help doing stuff like accessing public transportation, doing laundry, and other household basic activities of daily living, tasks, etc. Um, so, and it's that kind of repetition that people with brain injuries, and it's really not bad for everybody. The more, as they say, practice makes perfect. So somebody can get, the service coordination, the structured day program, the positive behavioral interventions and supports, community integration counseling, and independent living skills training. 5 people who are basically teaching the same thing in different settings, and eventually that's kind of how, and with sometimes different approaches, pretty hands-on, and that's basically how it eventually sinks in for, it's kind of more of a recipe for success. So I think that there's something to be said about that. A daily structure of each day, like when I worked in a brain injury center, we didn't necessarily have a rigid center. It was very person-centered. Whatever somebody really wanted to do, they could do. But most of the time, people came in, they had breakfast, they played cards, and then things kind of evolved from there. But just to have a basic routine that people generally do, and when you think about it, we mostly all kind of do. We get up, we have breakfast, we get ready for work, we go to work, and it's basically the same. Of course, we do a lot of everything in recreational therapy, but it's basically the same kind of somewhat structure, and that is kind of gives a sense of normalcy for people. Some people need extended time for processing information. Definitely people with brain injuries and other mental health issues and developmental disabilities as well. It might take them a minute to process information. So, I'll allow them a minute to kind of understand what you're saying, or even ask a question in a different format if it seems like they're having a little bit of trouble processing. So that's kind of one area where, one practical accommodation and strategy to use for working with various people. Offer, and this kind of goes along with it, offer directions in multiple formats. Sometimes it's good to have a written set of directions and go over it with people verbally. And even offering directions one step at a time, because some people have trouble processing more than one thing at a time. And as well as have people maybe repeat directions back to you so that you know that they understood what you were saying, and as well as you can even show them how to do something and then they could do it themselves. So, that's called scaffolding in the world of education. Active listening and empathy, definitely another very important area that I believe can be very useful. And repeating back the essence of what somebody said. Say Betty was talking about reconnecting with her long lost grandchild, and she was saying how she just ran into that person at a store. She just ran into her long lost grandchild, and it was a big reunion. And you could kind of say, yeah, you seem to really enjoy, and really that must have been very special to you, running into your long lost grandchild and reconnecting with the whole family, and it seems really nice. So, and of course, the eye contact and facial expressions, like you're really interested, and actually engaging in a conversation, asking questions for more information about what that person is saying. All kinds of gives the impression that you're listening. So just being very genuine and listening actively, and kind of clarifying what that person's saying. I have a hearing loss, so I might say to somebody, repeat that again, please, and I'll put my ear kind of up, hold my ear kind of up like I'm listening, and that kind of conveys that I'm really interested in what they have to say. I really want to understand their world. I want to understand the phenomenon behind their worldview and what they have to say, and know that that's important to me, and that I'm really trying to understand them. So I think that genuineness, that empathy, that love, and that's kind of what person-centered care is all about. It's kind of based on Carl Rogers' philosophy that you need love and belongingness to get self-esteem and then self-actualization, as part of Maslow's hierarchy of needs to reach your full potential. So, this is all, a big part of what we can do to help make people, help people reach their full potential. Let's see. In conclusion, please get a hold of me anytime with any questions, comments, etc. 845-987-0104 is the best number to reach me at. I gotta, I would encourage you all actually, danschiavo1@gmail.com. Yeah, that might be even better to get a hold of me than my work email address, and I'll have to put that up as well. So, thank you all for coming. I really appreciate it, and please let me know what you think. Please let me know if there's anything I can do to help, and I would love to know what you think. All right, signing off. Have a great rest of the conference. Okay, escape. Structured day program helps, in the community, helps people to improve and maintain skills and live as independently as possible. And the service planning, as I was saying, helps the people kind of choose which services and supports they want. And it's very person-centered. Like, you pick your service coordinator. You pick the programs that you want to belong to and not belong to. It's very person-directed, I would even say, even more so than person-centered. And I think that's really what care should be, because really, just like the rest of us, the people with the brain injuries have to be, you know, they have to live their own lives and make their own decisions. So, and they have every right to do that, just like we do. Independent living, skills training helps person live as independently as possible. Self-care, task completion, medication management, problem solving, running household, and